morning, everybody. I thank SICOT for giving me an opportunity to share my work experience here. Greetings from India. We'll be talking about the proximal tibial fractures treated by intramedullary nail. Most of the times, plating is the option used, but as a variation, we'll try to assess the feasibility of the intramedullary nail. We know that the proximal tibial fractures are inherently unstable. There is the valgus deforming force proximally because of the anterolateral and the posterior musculature, and there is apex anterior angulation. These two would cause residual displacement if it is treated conservatively, most often resulting in malunion and sometimes non-union also. So what are the treatment options for proximal tibial fractures? The first thing that's routinely used and extensively used is the plating, wherein less contact, less invasive stabilization system is used and plating is done, and we have seen that they have reasonably good results. The other one is external fixator used in compound injuries. And thirdly, intramedullary nailing, which we'll be discussing today. We have tried to use intramedullary nailing because it's a load sharing device and more biological way of fixation. How are we addressing the problems that we mentioned before? The valgus deforming force is addressed by making an entry point more proximal and lateral than the routine entry point. And the entry point is, you try to use a straight awl, make an entry point, try parallel to the anterior cortex to eliminate the apex anterior angulation. And we do the proximal locking in relative extension of the knee. Sometimes we use unicortical plates and polar screws, and we have some nail attributes which we'll discuss in the slides to come. As we see that the routine entry point of the intramedullary nail would actually manifest and exacerbate the valgus deforming force and maintain it. So it's no good. Actually, that's why we try to use a more proximal and lateral entry point, as we see here. As we notice here, if you use the routine entry point over there, it tends to open up the medial side, giving valgus force. However, as we shift it more laterally, it tries to close this deforming force. Also, as we see on the right-hand side here, if we direct the awl posteriorly, it tends to open up the fracture site with apex anterior angulation. However, as we go parallel to the anterior cortex, it tries to close this anterior apex angulation. What are the attributes of the nail that is different from the routine interlocking nailing? One is the more proximal Herzog bend and a lesser Herzog bend of 7 degrees, and oblique proximal locking bolts are used for axial stability. In spite of all this, our post-op protocol is delayed knee mobilization because there is very little endosteal contact in the proximal fragment with the nail, in spite of the oblique locking bolts being used. Material methods, we included proximal tibial fractures with very minimal intra-articular extensions in this study. It's also segmental fractures. We excluded type 3 open, pathological, and bilateral tibia. We had overall 28 cases, an average age of 41 years. Have 22 closed, 6 open, 2 of them are segmental and 1 with intercondylar extension, followed up for an average of 17 months, and monthly follow-up with X-ray and assessment with lower extremity function scoring. The lower extremity function scoring is a comprehensive score which has a maximum score of 80, and associated injuries included 1 knee dislocation, 1 compound femur, 1 closed femur fracture, and 1 ankle and calcaneal fracture of note. So all the fractures united at final follow-up, so there were no non-unions. There were 4 delayed unions, 2 of which required iliac crest autografting, 1 required dynamization, which was done distally, and 1 required exchange nailing and iliac crest grafting, which was done after a period of 1.5 years of looking into whether it's going to unite or not, and we did an exchange nailing and iliac graft, and finally it united. So 3 malunions, 1 was acceptable of 5 degree virus and 1 5 degree valgus. 1 was significant, 7 degree of virus. 3 infections, because we had a couple of compound cases also being managed. 2 superficial managed just with antibiotics, and 1 deep managed with antibiotics and debridement. However, this patient had a bad prognosis in terms of he had extensive scarring and also went on to have reflex sympathetic dystrophy. And In terms of range of motion, we had good knee and ankle range of motion in 25 of the 28 patients. 2 patients had limited range of motion. This was one with dislocation and one with a compound femur fracture. 1 patient with an ankle range of motion restriction had a calcaneal and medial malleolar fracture. Apart from that, the rest of them have good movement. So the results, we see the LEFS score of more than 72 in 89% of the patients, and 2 patients with less than 72 and 1 patient less than 60. That's case 1. We see that's the nail with a proximal entry point, oblique locking, and it's case 2 with the segmental, and we use the same technique, fixation. And this case 3, we see the segmental one again. We used here a unicortical plate in the upper part to stabilize the proximal fracture, and we have used a routine nail. This was done in the initial phase of our study. So to conclude, it's acceptable and a safe design with 89% good results. The nail design has a proximal Herzog band and oblique locking. Entry point is more posterior, proximal and lateral. Straight awl is used, which is going parallel to the anterior cortex, and fracture is sometimes kept in reduction with a KY or in extension while reaming and during proximal locking, and delayed knee range of motion is advised. Thank you.